Thank you so much. It's my pleasure to be here. So, today we're going to be talking about a topic that's very near and dear to my heart. And we'll be talking about visceral organ Doppler. And if you're not familiar with it, don't despair. This is not a very common topic. This is actually a novel technique that's being used to assess volume status. Now, I'm going to commit the mortal sin of quoting myself. And I always say that we can learn more about the heart by actually examining the organs that it actually supplies. So the objectives of this talk are going to be very simple. We're going to go over very briefly the traditional means by which we assess volume status and see how flawed it is when it comes to different physiological or pathological situations. The bulk of the talk, we're actually going to introduce what are these novel parameters that we look for, the visceral organ Doppler, how do we interpret portal vein Doppler and hepatic vein Doppler. Very important, we're also going to look at different congestion phenotypes that kind of changes the way we look at volume status and how to incorporate this very simple ultrasound technique to help guide when it comes to volume status. I'm going to go through some very distinct illustrative case examples. These are real-world examples. And lastly, I'll talk about the current research that we're doing and the future directions and where this is headed. So I'd like to apologize in advance if this looks anatomically inaccurate. These are actually my own original illustrations. Okay? So we need to take a journey back in time, and we need to go back to Guytonian physiology. The cardiovascular system is very simply divided into two sides. The cardiac output side that provides and perfuses, and then the venous return side. We as cardiologists, we do a really good job when it comes to managing the cardiac output side. Mean arterial pressure is a very well-recognized resuscitative target that we use. And we know that mean arterial pressure is the product of cardiac output and systemic vascular resistance. And in our daily practice, we manipulate these key components in order to maximize MAP and to maximize how much perfusion we are providing to the organs. Let's face it, we're in the business of providing oxygen or delivering oxygen to the tissues. And we all know very well that if we maintain good hemoglobin and oxygen saturation, the biggest driver of oxygen delivery then becomes cardiac output. This here is actually what we do almost on a daily basis, whether it's in the CCU or a sick post-op patient. But then welcome to the dark side of the moon, and this is the venous return side. And the venous return side is often not talked about. We have to understand that in order for us to get forward flow, there must be an upstream and a downstream pressure. So if you have a normal right atrial pressure of between 0 to 5, and your MAP is around 75, you're always going to have that upstream pressure greater than that downstream pressure, and you're always going to have that forward flow. When you start to look at the venous side from the post-capillary venules, the capacitance vessels as they become resistance vessels, you'll notice that there must be some gradient at the post-capillary venules that is driving flow to the right atrial pressure, to the right side of the heart. And that's what's known as mean systemic filling pressure. And this has been measured experimentally, and we know it's around 8 to 10. So you can imagine that very delicate differential between the mean systemic filling pressure and the right atrial pressure. The olden days of giving patients fluid and trying to tank up their central venous pressure to double digits will lead to a high right atrial pressure when compared to the mean systemic filling pressure, and that will lead to venous congestion or an increase in pressure. And how will this manifest clinically? You'll start to notice that your LFTs go up, your kidneys, your creatinine may get worse because of venous congestion, and you'll also have more congestion in the sphinctic circulation. All the while, you've already been maintaining a normal MAP. So over the years, over the last decade or so, we've really come up with concepts that help us decide whether or not we've given this patient enough fluid. One of these very popular concepts is volume or fluid responsiveness. Now, we define it as an increase in stroke volume of more than 15 to 20%. A good way to understand this is that if you give a fluid bolus and you're not increasing stroke volume, like what's happening here with that next bolus, you are contributing to nothing more than increasing your right atrial pressure rapidly and leading to more fluid and venous congestion in the organs that I just mentioned, as well as extravascular lung water. And so we really don't want to really reach that point, that flat point in that Starling curve, because in doing so, all that fluid will lead to more multi-organ dysfunction and worse outcomes for our patients. So now, in order to understand where we're going, we need to understand where we came from. So the historical perspective when it comes to fluid status is that we used to give patients not too much fluid, for example, for septic states. With early goal-directed therapy, we started over-flooding our patients, especially septic patients, and we used over-judicious fluid resuscitation. This led to clear evidence of multi-organ dysfunction and poor outcomes. We became very aware of indiscriminate volume loading and what it does to our patients, and so ultimately we had to find some better means of assessing volume status. The problem is that we can't place a swan in every single patient. And that old trusty swan, if you look at previous evidence, especially in the critical care literature, it doesn't show much benefit. Now, obviously, this was in a mixed ICU population. There were some inherent problems with the study design, and it was a very mixed population, as I mentioned. We're starting to see more evidence that the use of these right heart caths are extremely useful, especially in patients who have biventricular, univentricular shock, or who are on mechanical circulatory support. So what we started to do is to rely on more non-invasive means of measuring volume status. And I call the IVC the false prophet. Why? If you look at the left, this is a completely normal patient who has a collapsible IVC. The only difference between this and the other is that the patient got intubated. And when the patient got intubated, you can clearly see that the positive pressure leads to an increase in the IVC diameter. This is not related in any way, shape, or form to an increase in volume status. However, if we fixate on the IVC, the next step reflexively is always, hey, I think the IVC looks big, let me diurese the patient. This is clearly an example of compartmentalization of fluid. Another good example I always give is if someone develops obstructive shock from a PE, a saddle embolism, what happens to their right-sided filling pressures? The CVP goes up, the IVC gets large. If you were to diurese a patient with a saddle embolism, you may cause great hemodynamic derangements. So why did the IVC fail? Well, because the IVC tells us the pressures of the right side of the heart. And that's all it tells us about the filling pressures. And we should try to move away from trying to equate IVC size or collapsibility with volume status. Remember, us sitting all here have collapsible IVCs. If we suddenly got septic, we still have collapsible IVCs. Why is it then when it comes to therapy, we try to bring those people so close to that flat part of the Starling curve? We should try and avoid that because this is what's causing poorer outcomes and more organ dysfunction. And we have this overwhelming need to resuscitate when we find these collapsible IVCs. And we need to steer away from that, as I said. So now we started to evolve a little more. Over the past 5 years, you'll see this big popularity in the use of what's known as the venous excess ultrasound scoring system. And what it does is it tries to simplify looking at not only the IVC, but also looking at other flow patterns in other organs, in this case, the hepatic vein and the portal vein. And you can see that it's a very oversimplified system where you have an IVC that may be normal and hepatic and portal veins that are normal, that's grade 0. And progressively, as the IVC and the hepatic veins get worse, you start to develop worsening on this severity scale. The problem with the venous excess scoring system is that, again, it tries to oversimplify nuance, and we really have to go back and understand physiology. So let's just talk about the key components of this VEXIS scoring system. Now, the portal vein is actually an amazing vascular structure. It drains the splanchnic circulation, the gastric, the mesenteric, the splenic veins. When you look at the portal vein, it's extremely easy to obtain this view when you're doing your point of care ultrasound or echo. It's just a simple placement of the probe on the right side, transhepatic view, and with some anterior tilting, you'll see that flow. How do we know this is portal vein flow? Very simply, it's hepatofugal. It's headed towards the liver, and you can see it's red, so we know it's headed towards the probe. What are the flow characteristics of the portal vein? And this is going to be very important. The flow from the splanchnic circulation is usually monophasic. It is flat, it is not pulsatile, it's like a venous hum or a waterfall. That is good, healthy vascular flow. As you start to give your patient more fluid or they become volume overloaded, that central volume overload or that splanchnic circulation starts to pressurize a little bit. And you start to pick up tiny little bits of phasicity or pulsatility. As the patients become even more overtly volume overloaded, you'll start to see this. This is a bad sign. This is pulsatility in your portal vein indicating a pulsating splanchnic circulation. This is the most accurate way of determining whether your patient has central volume overload. And this here is an example of the most extreme form of central volume overload. Notice that you have blue flow in the portal vein. So at a certain point during the cardiac cycle, you're actually having reversal of flow. And you can see this in the Doppler pattern because it actually crosses the baseline. So these biphasic waveforms are much worse than these pulsatile, and this indicates that something needs to be done quickly in terms of volume removal. Here's a very good example. On the left was a patient who was admitted with septic shock, got over-judicious fluid resuscitation, and you can start to see that the patient has now pulsatile portal vein flow, and that's consistent with central volume overload. They happen to be on 5 of norepi and 0.02 of vasopressin as well. When you see that patient, you know that that is excess volume that's not contributing to stroke volume. And so the first thing we did was we diuresed the patient. And as we diuresed the patient, we opted for normalization of these portal vein flow, and we flattened that flow. This is whilst the patient is still on pressors. And as we diurese the patient, you can clearly see that you could get the patient off the pressors. So now comes number 2, which is the second component of that VEXUS scoring system that I was telling you about. And this by far, I think, is the most informative part. And this is called hepatic vein Dopplers. Now, if you look closely, the hepatic vein Doppler is just a change in nomenclature, but it's exactly the same as the jugular venous pulsations that we see. The only difference is that a line is drawn here and that it actually divides it into retrograde flow and antegrade flow. Antegrade flow during systole, antegrade flow during diastole. And so really, if you start looking at it from a simplistic standpoint, the body functions better when there's more flow that is going forward. So antegrade flow during systole and diastole is good. That's good vascular flow. And you have a little bit of retrograde flow, which actually represents the atrial contraction. Now, the hepatic vein Doppler, similar to the portal vein Doppler, is a very easy thing to obtain. In fact, it's a part of our full echo that we do. But you can also get good views from that transapical view, transhepatic view that I was talking about. And you can pick up either of the veins, hepatic veins, and again, it lines up beautifully with your angle of insonation, and so you can actually look at the flow patterns clearer. So the question is, do we really even have evidence for this VEXUS scoring system? And the answer is yes, there is much more compelling evidence. There's an extremely strong correlation between the VEXUS score and invasive right heart cath numbers, particularly right atrial pressure, mean PA pressures, and occlusion pressures as well. Not only that, VEXUS scoring systems were done in a subset of patients where they were admitted with high PA pressures and high right atrial pressures, and the VEXUS scoring system correlated with a decrease in their filling pressures as well. Excellent AUC properties. You can clearly see it can identify and discern patients who have right atrial pressure of greater than 10 and the numbers about 0.9. So extremely helpful in those patients at the bedside where you don't really have invasive monitoring. Now, the problem I have with the VEXUS scoring system is that it only looks in a somewhat binary fashion. Are the hepatic veins normal or abnormal? And that's how you go up on that severity scale. But we need to be very careful how we interpret the hepatic veins, because the hepatic veins are the back seat of the right heart apparatus. So problems of the atria, tricuspid valve, RV, and pulmonary pressures will reflect on the hepatic veins and not so much the portal vein. So for example, if you have someone who's taking a deep breath in, this increases venous flow, and so you'll notice that antegrade flow increases. But if you're breathing out, you'll notice that the retrograde flow will increase. And this may be confused with someone who may have some abnormality with hepatic vein, when in essence, this is just normal breathing. And here's an example of a patient taking a deep breath in. Look at that augmentation and increase in the S and the D waves. Another example of a deep breath, and you can see that the hepatic veins have gotten larger. Here's someone who took a deep breath out, and look at that sinus reversal wave and that reversal wave during diastole as well. Atrial fibrillation and atrial flutter. Remember, hepatic veins are a window to the right heart, and the atria play a very important role. We know the importance of AV synchrony. Here, for example, you've lost your atrial kick. What have you noticed with the S wave? The S wave has become much smaller. It's diminished. Why? Because without that atrial kick, it doesn't augment the systolic flow. If you look at this, you may chart this as systolic blunting, but this has nothing to do with the tricuspid valve. This has everything to do with loss of atrial kick. And here's an example of someone with atrial fibrillation and clearly blunting or abnormalities of hepatic vein. If you were to use the VEXA scoring system, you would have given an extra point for abnormality when this is actually due to AFib. Example where you can actually pick up flutter waves, another example of flutter waves, and no true or actually diminished S waves. So prominent atrial reversal waves, for example here, this is a patient who has AV-NRT. Clearly the P wave is so close to the QRS complex, it's contracting while that tricuspid valve is closed. What do? You get these large retrograde A waves. But if you look from afar, you may be fooled into thinking this is systolic flow reversal, and it's not. You have to have a good understanding of atrial dysrhythmias. Likewise, a patient who has this very rare clinical entity of tricuspid stenosis, look at those giant A waves. Has nothing to do with systolic flow reversal, it's just a stenotic tricuspid valve. And again, you may be scoring higher on the VEXA scoring system because you don't have a good understanding of the physiology. So basically, you start to actually create an understanding of the differential diagnosis according to what you see in the atrial reversal wave. Next comes the S wave, I think, which is the most important thing we need to look at. If you look at the bottom, normal flow, S wave is always greater than D. When you have volume overload or problems with the right heart apparatus, i.e. tricuspid regurgitation, RV dysfunction, or PA pressures are high, you start to see systolic flow blunting, blunting of the systolic flow. At some point, you may have even disappearance, but ultimately the worst form is when you have flow reversal, and this is when it looks biphasic. But remember, we have to understand that S-wave abnormalities occur because of these four major issues. Either a lack of contraction like an atrial fib, bad TR, a bad RV, or high PA pressures, or a combination of thereof. It's important to distinguish where exactly in the cardiac cycle this flow reversal actually occurs. So for example, when it comes to tricuspid regurgitation, we're talking about valvular insufficiency. And so when the RV contracts, as systole progresses, you're going to have a late systolic flow reversal. And here's an example of LSR, or late systolic reversal. And so again, it increases as systole progresses. But if you have predominantly RV systolic dysfunction, you have a weak RV, and so you see that systolic reversal early on. So this is early systolic reversal. However, again, these entities always occur together, and so when you have early systolic reversal with late systolic reversal, you tend to see what's known as pansystolic or holosystolic reversal, or those biphasic waves that I told you about. And this is really bad. This is DEFCON 5. This is someone with a poor RV who needs volume removal, who needs RV inotropic support, sometimes even mechanical support. And again, we start to see that it's not a simple VEXA scoring system, it's a complete understanding of physiology and understanding the differential with the changes in flow patterns in your S wave. So now we start to create an understanding, a new paradigm shift. Well, if we start to examine these flow patterns, we can see is that, especially if you focus on the hepatic, if you focus on the hepatic veins, you'll start to notice that there is a pattern here, that you can go from a simple triphasic waveform into a biphasic waveform. You can track your portal vein and watch as it becomes more pulsatile, and you can go the opposite direction and diurese them. And so now we're going back to the bedside, and we're going back to physiology, and we're going back to normalizing waveforms. Now, there is some more nuance as well. There was a recent article published last year that did an amazing job where they looked at a slew of different patients all coming to the ICU, and they incorporated these findings, these visceral organ Doppler waveforms. And what they concluded was, very quite simply put, 3 major distinct phenotypes. And we're going to go over them because it's quite interesting as cardiologists. You'll see that the swan may fail us. So for example, in a patient with hemodynamic congestion, a very good example is hypertensive urgency. Blood pressure goes up, patient is flashing, the left-sided filling pressures are going to be extremely high. The right-sided pressures can also be high as well. But usually in the acute state, you don't have enough time for that congestion to spill over into the organs. And so if you've floated a swan in this patient, you will notice high filling pressures, a high wedge, a high right-sided filling pressure, but the hepatic vein may only be slightly abnormal or normal, and the portal vein will be completely normal. Reflexively, what we would do with high wedge is what would we do? We'd diurese, right? But in fact, probably what's better for this patient is afterload reduction and a little positive pressure. Volume overload is another distinct phenotype. This is the septic patient who got 20 liters overnight. But they have very competent valves and they have preserved biventricular function. Because of their preserved biventricular function and good valves, you don't really have a stark increase in the left-sided filling pressures. The right-sided filling pressures aren't that high, they're just mildly abnormal. But you will notice a big difference or abnormality in the hepatic veins. But remember, the hepatic veins will never reverse in patients who have normal tricuspid valves. It can be abnormal and blunted, but never reverses. But the key discerning parameter here is that portal vein. And so you notice that this patient who got 10 liters now has pulsatile flow. And what would be the trigger? If you had a swan, you'd have not so elevated filling pressures, but you have evidence of organ congestion. The right answer to the question would be to diurese, and your swan may lead you astray. We have systemic venous congestion. We see these patients all the time in the ICU. And this is the patient who has bad biventricular function, bad valves, and they have extremely high wedges, extremely high right-sided filling pressures, and extremely abnormal hepatic veins. You can see the flow reversal that's going on here. And that's because the valve or the RV function is bad or the PA pressures are high. Not only that, you're completely congested. In these patients, they need a combination of inotropy for forward flow as well as aggressive diuresis. If they don't respond to diuresis, they need volume removal with renal replacement therapy as soon as possible, as well as possible MCS. I'm adding a different group as well, and this is what I call the right heart apparatus dysfunction group. In these patients who have RV dysfunction, your left-sided filling pressures are not going to be that high. You obviously are going to have very high right-sided filling pressures. But what do you think the hepatic veins are going to show? They're going to be chronically abnormal because you have TR and you have RV dysfunction. So the hepatic vein in these patients who have chronic right-sided issues is not going to be very revealing. In fact, you can diurese them all day and it will never normalize. So it's actually dangerous to try to target normalization of your hepatic veins. But what's going to be that discerning feature? And that's going to be the portal vein. So a patient who has pulmonary hypertension, we know how difficult it is to diurese them and volume strategy because they are very preload dependent. But we can use the portal vein to diurese them. But the question is, do you really want to diurese them to the point where they have monophasic flow? And the answer is no. Again, a very preload dependent state. You may want to give them a little more fluid and keep them a little bit on the pulsatile side. This is a very similar strategy I use for TAVR patients who have high risk for a suicide LV. You don't want to diurese them that much prior when you're optimizing them. So I make sure that portal vein is a little pulsatile before they go in for their TAVR. So now we start to understand that there's actually very interesting congestion phenotypes. Either hemodynamic, where you have high filling pressures on the left and the right, but the visceral organ Doppler isn't that abnormal, and so we shouldn't really be diuresing them, we should really be doing afterload reduction. Volume overload is when the filling pressures aren't that high, but there's clear congestion in the organs, and we really need to diurese them. Systemic venous congestion, extreme form where you have both high filling pressures and organ congestion, you need a combination of inotropy plus volume removal. And lastly, the right heart apparatus, which we know the left-sided filling pressures may not be that high, right is going to be high. You will always have abnormal hepatic vein Dopplers, and now you can discern between those who need more volume or less volume by examining the portal vein. We obviously are going to support the RV as we usually do, but you will decide whether you're going to do gentle diuresis versus optimizing the preload. So how does this work in the real world? Well, let's see some illustrative case examples. It's always difficult when you have some form of univentricular support, like a VAD or something. This is a patient who's actually, I think, a week or two ago, post-operative day 1 after an LVAD, came out with norepi of 8, epi of 8, vaso of 0.04, and inhaled nitric. When we examined the patient, the TE done during intraoperatively showed some moderate RV dysfunction. So you can clearly see on the left the hepatic veins show what? They show systolic flow reversal. We know that the right side's not doing well. But if you look at the right here, this is the portal vein. What do you guys see here? Pulsatility. Pulsatility is bad. It's not only pulsatile, it's crossing the midline. It's biphasic. So there's actually retrograde flow. So despite the fact that this patient's on norepi of 8, epi of 8, and vaso, and considerable vasoactive agents, we diuresed aggressively with Bumex strip and Diurel until we normalize this patient's portal vein. And as we diuresed them aggressively, we actually got off the norepinephrine, got off the vasopressin, and kept the patient on just a little bit of inotropy with dobutamine. So remember, rapid weaning of the vasoactive agents, and the most important key feature here is that the CVP and the PA pressures showed no difference whatsoever. Next, 67-year-old man, post-cardiac arrest in the setting of an anterior STEMI, got PCI to the LAD, worsening refractory cardiogenic shock, emergently placed on VA ECMO, peripheral VA ECMO. Now, I left a little diagrammatic illustration here that shows where's the hepatic vein draining into the IVC. What's sitting in the IVC? That's your multi-stage catheter or cannula that's draining. And so you may be fooled to think that this patient has normal hepatic veins. It's not true. This is because of the suction that's going on with that cannula. And the portal vein as well may also be affected. So this patient underwent just traditional ECMO weaning. The underlying shock resolved, off of all vasoactives, incremental decreases in flow. We monitored what we normally do, the MAP, the filling pressures, and markers of perfusion, and we did it under TTE guidance, TEE guidance. So the patient tolerated the ECMO wean, and then the patient was subsequently decannulated. He had normal lactates, and SVO2 was normal as well. It was actually 6 hours later, escalating doses of vasoactive agents, shock liver, AKI, elevated lactate, worsening cardiogenic shock, and the patient placed back on VA ECMO support. This is prior to the cannulation. What do you see? Complete flow reversal in the hepatics and pulsatility in the portal vein. This patient is floridly volume overloaded, and we probably should have diuresed more. So why the delayed decompensation? There was no interval clinical event. There was no change in clinical parameters. Echo actually showed improvement, and we did not give this patient volume. So it was actually congestion that was masked by the mechanical circulation. So therefore, why don't we try using a sonographic means of assessing congestion when we do the ECMO wean? And this is what we're doing right now in the CVICU. And so here's another example of someone on ECMO, normal forward flow. That means nothing to me because they have a drainage cannula. When we took down the flows to about 1 liter, what do you notice here? It's clear that compared to here, where you have antegrade flow, you suddenly have flow reversal. So we unmasked the congestion by coming down on the flows. So we made a clear decision, hey, we've detected congestion, even though the mean arterial pressure, even though the PA pressures didn't go up and everything looked normal traditionally, there was sonographic evidence of congestion. And so we did not decannulate the patient. We instead opted for more aggressive volume removal. And then 36 hours later, after we removed significant volume, I did another wean. And what do you see here? On flows of about 0.5 liter, you can now see that antegrade flow. And this is with the cannula flowing at only 1.5 liters per minute. And this patient did well. All right, let's up it a little bit. We've gained some popularity with the Bivacor. With the Bivacor, we're very limited in terms of how we monitor these patients. You can't put a swan. You're lucky if you can get the central venous pressure. And what's distinct about this model is with this total artificial heart, unlike in patients who have hemorrhagic shock where you expect a low filling pressure, it acts almost like a Stirling resistor. Because of the suction force, if you are hypovolemic and bleeding, your vessels actually collapse. That's called the resistance of the circuits on the right and the left, actually collapse like a Stirling resistor. And the calculated resistance is high, so you'll be fooled into thinking that this pressure has high pulmonary pressures, but that's not the case. In one of our Bivacor patients on day 1, this is antegrade flow in the hepatic, which is not very useful, but we clearly saw minimal pulsatility. We knew clinically that the patient was bleeding, gave them volume. But after 1.5 to 2 days of giving volume, what did we notice? Pulsatility. And we started diuresing as well. And so this is a very good adjunct in even the most complex of patients that you have. Lastly, this is a 28-year-old, few years ago now, but came in with tricuspid valve endocarditis, respiratory failure, and AKI. If you look at the tricuspid valve, you can clearly see that vegetation had rip-roaring TR. So what's the next step? The CVP from that central venous catheter is giving me numbers in the high teens. Our natural reflex is to diurese, but this patient has very severe TR. And it's very clear if you look here that you have an atrial reversal wave, an S wave, and what do you guys see here? A late systolic reversal, and that's severe TR. And when I look at the portal vein, it's only minimally pulsatile. So instead of diuresing this patient with a high CVP, we opted to give this patient fluid, and creatinine went from 4 to 3 to 2 to 1, and the patient went ahead and got their tricuspid valve replacement and survived. So where are we going with this? I think it's very important as cardiologists to start to adopt other aspects of organs in order to get a full picture of what's happening in the heart. Currently, we're collaborating with a lot of other sites to start prospective registries. We're going to look at the use of these visceral organ or venous congestion parameters in patients who are difficult, like pulmonary hypertension and RV failure. We are going to also, we already have a registry of almost 20 patients where we looked at Doppler assessment during VA ECMO, like that illustrative case example I showed you. And also a little more novel here is that forward flow is always good flow. And we're trying to validate a novel tool where we look at the area under the curve and compare antegrade to retrograde flow and develop a scoring system to help us decide which patients may need diuresis and which ones do not. With that being said, overall conclusions, these two aspects of visceral organ Doppler can help you a lot. It's easy to implement. I do a workshop for an hour, and after that hour, most of the people who do it are very proficient. And then within a few days of practice, they actually adopted it in their practice as well. I think as cardiologists, we're always very early adopters when it comes to new meds, when it comes to transcatheter devices, but we're very resistant when it comes to cheap alternatives and when it goes against what we've really been trained all our lives to do and what our forefathers have done. There is increasing evidence of support to use this. We have more research and research coming out from here, and it can be extremely useful in our complex cardiac patients. And with that, I'm more than happy to take any questions.